All right, it's 10 o'clock. I'm going to convene today's working session. Well, we are listening only to the New Hampshire Prescription Drug Affordability Board this morning. I know that Mr. White has other obligations that started at 10 o'clock, so I'm gonna Mr. Williamson, I'm gonna try to front load the kind of technical questions we may have after you do your presentation, so that Mr. White feels free to leave. Okay. All right. So with that, would you introduce yourself to the committee and for the clerk to put you in the record?
Absolutely. Good morning, everybody. I'm Kirk Williamson, and I am the Executive Director of the Prescription Drug Affordability Board.
Go ahead.
And Nathan White, Chief Financial Officer with the Department of Health and Human Services.
Okay. So I think everything on the Prescription Drug Affordability Board is on page 1054 of the budget, and the request is 100% general funds. In the next fiscal year, it's essentially 256.5 thousand, and then it goes up slightly in the second year, another 10,000 to 265.6. So that's that. But so my technical question is that in the last HB2, I think directed may be the right term. We directed that an account would be established with the PDAB so that it was able to receive community donations to support its operation. And as I look at the budget on 1054, I do not see a line item where you're ready to accept donations. Could you speak to that?
Sure. So Chairman Edwards is referring to the dedicated fund that was created in statute, and the Prescription Drug Affordability Board accounting unit 6273, that is 100% general funds from a funding source perspective. There are no other funds there currently. I don't know if you want to.
So to just clarify that, if that means the dedicated fund is not yet established, because if it were, it would be a line item here, or would it be a line item somewhere else? Class, I think you call it a class code 6273. Would it fall under there?
So the thing that I would just need to go back and verify and take a closer look at the statute is whether the accounting unit that's sitting before you would be considered part of that dedicated fund. I suspect that would potentially be different, but if the intent was for the other revenue sources to fund the operations, then we would see those other revenue sources here. And we may just want to take a closer look at the original statutory language on that front.
All right. So the intent of that in HB2 last year was to establish a form of other revenue to associate with the Prescription Drug Affordability Board, so that any donations received could be used directly by the operations. That was the intent, and I'm glad you're going to relook the statute, because I don't remember the statute, but I clearly remember the intent.
Absolutely. And we haven't been approached with donations as of yet, or that type of, we haven't been approached with any revenue.
Yes, sir.
The original legislation did have us funded through fees and assessments, like many other boards in the state. That shifted to 100% general funds, and we do have ideas that we'd like to talk with you about, Chairman Edwards, that we've been thinking about to be more self-sustaining.
Yeah.
And it could be an HB2 thing, but yeah, maybe we could talk offline about that.
So we can do all of that. My goal here was just to do the technical part of the conversation, so that Mr. White could feel free to go do the conflicting things. And then we'll talk. Yeah. Representative
I
Twersky.
respect the need for Mr. White to leave, but I'm wondering if the executive director can literally give us a 45-second summary of what PDEB is for the members that were not part of us last biennium here to have that conversation and knowledge.
We'll have that. Mr. White, are you preparing to say anything further?
Yes. So I'm looking at the statute. It's under RSA 126 BB8, and it establishes the non-lapsing fund, and it does specify that the board shall use the dollars consistent with the provisions of the statute, but may be used to pay for administrative, technical, legal support, and other costs incurred by the board. So it's not necessarily clear to me that the intent there was to supplant or replace the accounting unit that you're seeing within the governor's operating budget in 6273.
Yeah, the intent was to augment, to be a supplemental source so that we're not 100% reliant on general funds, but that we could, that without us directing the spending of those receipts, that would create flexibility for the board.
Yep, and so if as Kirk was indicating, if we were to receive any revenue, then what we would do is we would go through the standard process as dictated by RSA 1430A, where we'd accept the dollars through the fiscal committee and GNC, and then we would submit a memo to DAS, or DAS would go ahead and add those funds to that account, and then those could be utilized. But currently, because we have no dollars in that account, you're not going to see that show up here. It's similar to, I think, a few other scenarios where, for example, from yesterday with the maximum security unit, where because we don't have any history there, you're not actually seeing any account show up because there's no revenue.
Right.
And to have an expense, you need to have revenue.
Right. So, okay. So I have been thinking we had a chicken and egg situation, that first we had to create the account so that the board could solicit or encourage donations. That it was a stepwise, step one, establish the account, two, seek donations. But it's not that way. It's actually the opposite is what you're saying.
Well, because the authority for the account is already established in state law, what we would do is just submit a memo to, this is one of the things you don't really see here, but we submit memos to DAS, for certain
Right.
things. And this would be one of those things that would just transpire once we had money.
Right. So the takeaway from that is we've always been able to, or since that statute went into effect, we've always been able to accept donations. And based on the first donation, I think I donated $1 actually. I don't know where it went, but
I did not accept that dollar.
You did not accept
You
it?
offered me one, but I said I do not want to accept this because I don't want to spend that much time. I'm going to have to spend a lot more money to accept the dollar than it's going to be worth.
What's your break even? How much do I have to give you to have you establish the account?
I don't know.
Think about it.
Okay.
Okay, so I think we've hit that one topic, and if you would like to excuse yourself, no one here would be offended.
I greatly appreciate that. Sorry.
Yeah,
I
and
double-booked for
you're welcome to
GNC.
stay too. I'm not throwing you out.
Okay.
All right.
Thank you.
So with that transition, Mr. Williamson, go ahead and tell us everything you want us to know.
Okay. Thank you, Nathan, for being here. So thank you, Mr. Chairman and members of the committee. Again, I'm Kirk Williamson, and I'm the Executive Director of the Prescription Drug Affordability Board, and I appreciate the opportunity to speak before you today about the critical role we play in protecting New Hampshire residents, businesses, and taxpayers from the high cost of prescription drugs. I know this is a very challenging area of healthcare and just the issue writ large, so if you have follow-up questions or anything, I'm happy to make myself available to you whenever I can. So just to level set with everybody, the New Hampshire Prescription Drug Affordability Board analyzes prescription drug costs and their impact on public payers, taxpayers, and patients, and identifies cost-saving opportunities and makes public policy recommendations to the legislature. The board monitors market trends, promotes transparency, and advises the legislature and public payers on strategies to balance affordability with sustainable healthcare spending. In a short amount of time, we have already produced results. In our last report, we identified $6 million in potential estimated savings. If those negotiated rates were applied to New Hampshire public, state, and local employee health plans, we would immediately see reduced spending. We are formalizing a recommendation for a state-backed privacy-first pharmacy savings card that would be no cost to the state. It launched 2 years ago in Connecticut. As for one example, they are seeing an average of $240 of savings per script. That comes to $1.23 million in savings for the state.
So is that in the slide deck, that's the breakdown on that 6 million?
I included it in our accomplishments, but I can follow up with that information if that would be helpful for you.
Yeah, I think this is a
Sure.
kind of a critical issue because I think you all have been operating in statute for about 4.5 years, and there's been a tremendous amount of startup investment made, and I think you're on. I should, for disclosure, let people know I'm a member of the Prescription Drug Affordability Board. I think the board is on the cusp of being able to produce things. And I want to talk about the forward-looking part of how we're investing to get a return on investment. So the idea that we've already had a return, I think we need to understand that.
Sure. And so we were established in 2002. I was hired last year, so the board has been staffed with one full-time employee for a little over a year. And to your point, laying the foundation does take a lot of work, a lot of investment. There is rulemaking, data sharing agreements, getting the analytical processes in place. We now have those data sharing agreements in place. We are analyzing and tracking prescription drug spending over time. We are identifying areas of cost saving opportunities. We are in the process of formalizing a recommendation and working with the governor on this prescription drug discount card, but we can only make recommendations. I want to be very clear. We don't have enforcement authority.
Right.
We can't do anything about the price necessarily, but we can make recommendations and assist public payers and assist the legislature to that effect.
Sure. So just so you know what my frame of mind is on this, is that I do agree that there's been a period of time where we've had to ramp up and create a capability. And I didn't actually expect that your presentation would include any specifics on financial benefits of the past. What I really was thinking we would do today is talk prospectively on how this new money in this budget would be leveraged for, what we can expect from it. So the fact that you've got 6 million already,
Right.
I want to understand that because that's just kind of extra. And I want to let Representative Seaworth ask his question.
And my question was very much in line with, I think, where you're going. And we interrupted early on in the presentation. Maybe you'll catch up with this, with the slides. But what I'm wondering is the 6 million, as I understand it, is a potential savings. And there's a path that will get that to actual savings to the state. And if I could get an idea of what's missing between here and then and how we get there, and I'd like to understand that. So exactly what you're saying. I want to turn the potential savings we have on the table to what is that a couple years from now in terms of savings that more than pays for what we're doing to get them.
So this is just new information to me. I don't know how I missed our $6 million recommendation.
Sure.
But if you before we end,
Yeah.
I would like to understand what the form of that recommendation was, who received that recommendation, and what we think the prospectus is on those recommendations being accepted and converted into savings.
Right. Right.
Do you want to do that now, or do you want to get into the rhythm of your presentation?
I can attempt to answer it. I can attempt to answer it, but then I'll get back to the presentation. We examined, so part of prescription drug pricing, PBMs negotiate rebates. And after the fact, after you do all the spending, you get some form of rebates back and it lowers your net cost, or that produces your net price. Rebates are very secretive, they are confidential, they are privately negotiated between manufacturers and PBMs. We at the PDAB don't have access to those rebates. Nobody is sharing that information with us, but we are trying to get there and we're trying to analyze spending by looking at the net price, okay? So we did an analysis that looked at estimated what our current rebate capture is for just 10 drugs that were negotiated by Medicare. These are the first 10 drugs that were
Medicare,
negotiated.
Medicaid?
Medicare, because Medicare can now negotiate a limited set of prescription drug prices.
So I'm confused. The focus of the PDAB
Right.
is to save state payers money.
Right.
You're referring to a federal program.
Right.
So I'm confused by the jump.
Yeah. So Medicare operates just similarly to how we operate at the state level with commercial plans. So Part D is a commercially administered plan. It is subsidized by the federal government, but they also use PBMs. And so the secretary was barred from negotiating up until last year, and starting with 10 drugs. And so now all of those plans benefit because now they have negotiated prices, and those are known net prices. We have no other benchmark to know if what we're paying is more or higher than what we should be paying. And so when we looked at what negotiated price did Medicare get, which is now public, and they are increasing the number of drugs over time, we can then say, this is what we're missing out on by not leveraging those rates. And so this was, in our first attempt, we identified 6 million just on those first 10 drugs that are some of the highest cost drugs to the state plan, to local plans. And yes, that is an instructive benchmark. And we're hoping that over time, as those savings get larger, we can hopefully have plan sponsors come together and figure out a way collectively that we could negotiate those rates. It was contemplated at the federal level that states in the commercial market would have access to those negotiated rates, but that was not enacted, unfortunately. But we have opportunities at the state level to think creatively about how we could do that. And so that's where our savings estimate came from.
So to summarize, I think you're looking at the example of Medicare, seeing
Yeah.
those 10 drugs, seeing the change in the pricing.
Right.
You think we can take that military term intel and convert it to our Medicaid and other state purchasers so that they have a roadmap to achieving equivalent savings
Yes.
at the state purchasing level?
Yes.
All right.
Yes, yeah. And
And-
there
and
are
how have we
there are
commu-
international benchmarks. We could sit here and say, well, Germany only pays $10, but we pay $300. But
So-
it's probably unreasonable that we would get 10. But this is a closer benchmark to something that is real and actual.
Right. And U.S. based.
and U.S. based, exactly.
So how did we communicate that to the purchasers of New Hampshire drugs? And that's DAS, I guess,
Yeah.
corrections,
Yep.
other entities within the state, like, Mr. Lippman and Medicaid.
Right. And Medicaid is a bit different. They have a
Yeah.
different.
But how did the board communicate it to
Right.
the purchasers so
Right.
they know the
Right.
board has made a recommendation?
Well, we estimated the savings. We have not recommended reference pricing. That's not a recommendation that the board has made. But we are building the evidence and we are demonstrating what the savings could be, and we are communicating it by sending it to them, by alerting them to what we have found. We have an advisory council that we established last year that does consist of the unions, the Department of Administrative Services, DOJ, HHS, Medicaid, the Department of Corrections, CCSNH, the community colleges, and the university system. So we do have feedback loops. We only established the advisory council in August. So much of this is being built as we're flying the plane, but that is how we have gone about it thus far.
Okay, so what I'm thinking I'm hearing you say is that you're using the advisory board to communicate this potential savings, and you're doing it through
That's one
formal
avenue.
meetings of the advisory board.
That's one avenue.
You haven't documented it in an official letter from the board to send the letter to like Mr. Arlinghouse and say,
Right.
we haven't done that step, but you've been talking through the advisory council.
Right. Exactly. And if we wanted to, we could. I like that idea. I mean, you're on the board. I also think that's a great idea. But we haven't done that yet. No.
Okay. All right. Are there any questions at this point or what? Okay.
Thank you,
So-
Mr. Chairman. So your presentation is very well put together and you're sort of going through it through questioning. So I just want to make mention of the fact that the advisory council of which you are referring
Right.
is on page 12 and the
Yes.
members on page 13
Yes.
of your very well put together handout so everyone
you.
can get a good grip on where that advisory council is found in law,
Yep.
their terms, their meetings, and the membership. So
Thank you.
you're already on page 12. This is amazing. Thank
I
you.
am.
Thank you, sir.
Yeah, I don't want to skip 7 though.
Oh, is that?
I'm sorry to interrupt.
Oh, no, go
Can
ahead.
we have him, even if it's quickly, he highlights the highlight of each page as we flip through? I feel like we have done ourselves a disservice here.
I disagree. I think this is compatible with other presentations where we've asked them questions as they've gone through the slide deck. And we had one change in that we needed to let Mr. White leave early.
I'm fine with that. And you, sorry, I didn't mean to interrupt you. Continue.
So I think our approach is consistent, and I've been trying to get back to letting Mr. Williamson drive through his presentation.
Great. And if I could make the request that we
So
maybe,
you mean that sincerely, that's great?
That is great,
your-
'cause
your
I would
tone of
like him to-
voice
I'd like him-
Doesn't sound like you think it's great.
I'd like him to continue through because I feel like, as my original request at the top of the hour was to do a quick high-level explanation for new members that I feel we just haven't even got. But
I
at this
think
point,
next term, when you're the chair, you can do that. All right.
Okay.
We're going to try to let you get back through your presentation, but you've made some points that I wanted to get clarified.
Okay. Okay. Great.
And I think those clarifications have strengthened your case.
Awesome. Great. Thank you. Okay, so slide 2, going back to slide 2. This is the mission, goals, and objectives of the board. We spent a lot of time last year developing this. It was no small feat, but our mission is to serve an essential public function by analyzing prescription drug prices in New Hampshire and making recommendations to public payers and the legislature. And then you can see our goals and our objectives. Moving on to slides 3 and 4, rising prescription drug costs are a statewide issue that impacts the budget at every level.
So I need to ask you another question, though, on page 2. The third bullet, protecting patient access to essential prescription drugs to improve.
Yeah.
Is that directly related to RSA 126BB, or is that an implied mission that the board has adopted for itself? I just want to
think
know
when
the
we were-
distinction between what you're required to do in law and what
Yeah.
you're required to do because it makes sense.
Yeah, I don't, there's no statute that says that.
Right.
No.
But there is one that talks about the recommendations, the second.
Yeah,
That's clearly in statute that we're supposed to make these
clearly, yeah,
recommendations.
yes, yeah.
Okay.
Yes, sir.
And that's why I was talking about that letter, because I think since
Yeah.
that's in statute, we need a record of what recommendations we're making so that can
Right.
be, yeah.
Okay.
So go ahead.
Okay. Okay, so rising prescription drug costs are a statewide issue. It affects public payers, businesses, and households. According to a recent New Futures survey, 53% of Granite Staters are worried about affording their prescriptions, and 1 in 4 Granite Staters skip doses or ration their medications due to high costs. State and local governments, they're under increasing pressure. Prescription drugs are a major cost driver in Medicaid and in public employee health plans. Small businesses, they struggle to stay competitive as health insurance premiums rise, and it makes it harder for them to hire and retain workers. Families are also having to make very challenging decisions. Many Granite Staters are forced to deplete their savings, take on credit card debt, or delay necessary care due to the high cost of prescription drugs, which we don't see as sustainable. The cost trends indicate continued strain on our economy unless we are able to take proactive measures. And so this is where the PDAB comes in. Slide 5. I'll now walk you through some slides just to give you an overview of our budget request and who we are. Let me flip to that real fast. So starting on page 6, the governor's budget maintains stable funding. It allows the board to continue its critical work. Our budget is highly efficient, totals $256,579 in FY26 and a small increase in FY27, which is really a fraction of the state's $13 billion it spends on healthcare. As you'll see, that personnel costs are the main driver, funding one full-time position to execute on all of this work. But despite these limited resources, the PDAB has already identified savings, which proves the value of continued investment. And if your intention is to continue funding the board, and we hope you do, we did distribute a technical amendment that would continue the executive director position, so the board would have stable leadership and staff to execute on its mission. And so by continuing to fund the PDAB, we are signaling to Granite Staters that we hear them and we take their concerns seriously. Moving on to slides 8 and 9. The board, we operate transparently. All of our meetings are live stream and open to the public. We regularly engage stakeholders across the healthcare system. The PDAB is comprised of legislators, health economists, pharmacists, lay experts, which really helps to ensure that there's a broad range of perspectives. We have regular meetings that allow for that type of stakeholder engagement and helps to ensure that we stay ahead of emerging affordability challenges. All of our materials, presentations, reports, all of our decisions, it's all publicly available and on our website. I'll then jump to slide 10.
We're gonna want to come back to 7, but keep going.
Okay.
You,
do you just
you're
want to?
fine for now. Keep going.
Okay.
But I just don't want to overlook 7.
Okay, I'll make a note of it. Slide 10, that provides an overview of the PDAB's authority in our reporting. Chairman Edwards mentioned, our primary objective is making cost-saving recommendations to public payers and the legislature, but this is some of the things that we're tasked with doing. Slides 11 through 14, as already made mention, it details the advisory council. So the Stakeholder Advisory Council was established last year, and it ensures the board's work is reflective of state leaders representing a diverse cross-section of state government that all touch on prescription drugs in some way. And the members really help to guide the work of the board and ensure that key voices have a seat at the table. Moving on to slides 15 through 17. These slides are intended to provide you with key insights that we uncovered in our 2024 analysis. As you can see, the top 25 prescription drugs, they're brand name drugs, and they accounted for 44% of total prescription drug spending, revealing a small number of drugs are driving increased costs. And so understanding these trends is critical for negotiating better rates, ensuring competition, and protecting New Hampshire taxpayers. This year's report will incorporate prescription drug spending under the medical benefit, which is a growing area of concern that is highly concentrated with high-cost biologics and provider-administered drugs.
So spend a little time there for
Sure.
the education of the members.
Yes.
The medical benefit, how does that compare to what we're already looking at? We would all
Right,
assume
right.
a medical benefit comes from all pharmaceuticals, but you're making a distinction here.
Right. Thank you. So we analyze prescription drug spending under the pharmacy benefit. And pharmacy benefits are typically administered by entities called pharmacy benefit managers. They are middlemen who negotiate rebates in secret. They have their own pricing strategies. It's often very challenging to know what you're actually paying at the end of the day. But all of that is administered under a PBM. They have no fiduciary duty. So they have no fiduciary duty to the employer, to the plan sponsor. They simply administer that benefit. And this is all of the drugs that you would get at your CVS, your Walgreens, all the retail stuff. The medical benefit is often provided separately than the pharmacy benefit. And the medical benefit would capture spending in hospitals, spending under a bundled payment in Medicare, or an outpatient facility, all of those types of drugs, provider administered drugs, infusions, IVs, those types of drugs. The medical benefit this is getting weedy, but it's very complex in the terms of of the claims that are coming in. It's not just by NDC, which is typically how the claims come in under the pharmacy benefit. Under the medical benefit, it's HCPCS, it's J
Careful with
codes.
acronyms. NDC.
NDC is the national drug code. Every prescription drug has a national drug code. It's an identifier for the drug.
Right.
And then under the medical benefit, you have the healthcare procedures codes, HCPCS. Those relate to procedures, and then within them, there are certain prescription drugs for that procedure. That takes a more work and effort, but we have done the crosswalk, and so we are incorporating that spending under the pharmacy benefit. I mean, under the prescription drug spend for this upcoming report. But those are kind of two different ways of administering how we pay for prescription drugs. One really relies on rebates. That's the pharmacy benefit, and the medical benefit that's often paid off of like the average sales price in Medicare or something.
Right.
Okay. So just moving on to our accomplishments. As I mentioned at the top of the hour, we identified $6 million in savings using the Medicare maximum fair prices as a benchmark. We also modeled spending on Humira, which only recently had a biosimilar launch. It enjoyed well over 20 years of patent protection, and is still our #1 top spending drug, even after biosimilars were introduced into the market. And so that led to legislation that is active in the House right now that would help to improve competition among approved biosimilars, which is a very, very expensive category of drugs. And then we're in the process of vetting and formalizing a recommendation for a pharmacy first discount card that would be no cost to the state, open to all Granite Staters. And based on Connecticut's experience, we could save up to about $240 per script. And with how many people they have enrolled in the program, that's $1.23 million. That's cash pay. That's people that are maybe in a high deductible health plan, or their drug was dropped from their formulary. It would help really benefit those who are underinsured or uninsured, or on fixed incomes, retirees, those types of folks.
So 2 questions on
Yeah.
this on page 18.
Yep.
Again, for the education of
Yep.
folks.
Yep.
The distinction between biosimilars and generics.
Yes. Generics are small molecule pills. So there are brand name small molecule drugs. That's Advil, Tylenol. Anything that's a pill or a tablet is a small molecule. Then biologics are large molecule drugs. Those are provider administered IVs. You can think of drugs like Keytruda or Humira. Those are biologics. Biosimilars are, you can think of them as the generic to a biologic. They have a much longer market exclusivity period. They enjoy much longer terms of patent protection. And the litigation for biosimilars to enter the market is at a much higher bar than what it is for generics. So we have not seen the entry or the competition among biosimilars manifest like they have for generics, but we're doing everything we can at the state level to help facilitate that.
And in general, is it easier to get information on the generics than it is the biosimilars? Or
Right.
what's the source of our biosimilar pricing?
Yeah, anything that would come in through claims. Once the drug is approved, then it would either be covered or not covered by a formulary, and then we would be able to analyze that spending. We didn't have any claims for any biosimilar for Humira last year, but it was only introduced we analyzed 2023 data. That's the only most recent data we had last year. So this year's analysis, we'll be able to see or measure what was the biosimilar uptake. But there are other distortions within that market that may limit competition, but that's for another
You're
day.
referring to claims. Do you mean Medicaid claims or also commercial claims?
The commercial claims, so the state and local employee plans that we are tasked with providing recommendations to, all of that data is submitted to the All Payer Claims database, and so we leverage that database for our spending analyses.
Okay, and then the third bullet.
Sure.
What department or how would the state implement that if that were to be chosen? Is there already like the Department of Insurance or somebody that
Right.
would receive this as a task to make happen? Or how would we implement that?
Right. I think that's a question that we are hoping to address in our upcoming board meeting.
Yeah.
We have had productive conversations with the
Okay.
governor's office. She's vetting it. She
right.
has her staff vetting it.
Nope,
That
nope.
could be something we take on, but okay. And then, looking ahead, we are eager to work with the legislature and the governor on launching this discount card for all Granite Staters. We'll continue to issue recommendations on prescription drugs that may pose affordability challenges. We're strengthening our interdepartmental collaboration to facilitate data sharing, minimize redundancies. And then we are also exploring opportunities to strengthen pharmacy benefit manager contracting and transparency requirements. So there's a lot of work underway. We have really appreciated the support. Chairman Edwards, you have been very helpful in establishing our processes and policies and getting us to a place where we feel like we are empowered to make these recommendations. So I just want to acknowledge that.
Sure. And for the people who have been tracking this for 4 years, there was some initial concern about redundancies. And I think in this last year, we've cleaned up some of the redundancy issue by clarifying that the board does not collect data and
Right.
store data.
Right.
It relies on existing procedures and departments to do all of that, and that you submit sort of a data analysis request instead of owning the data and the risk associated with it.
Right.
So that was a huge concern about redundancy that I think you could have shown as an accomplishment.
Yeah, thank you. We did go through that exercise last year with the insurance department and presented that in December to the HHS committee.
All right, Representative Daniels.
Thank you, Mr. Chairman. How does this proposed pharmacy discount card differ from something like GoodRx
Yeah.
or an AARP discount card or any other ones?
Yeah, that's a really great question. So GoodRx, not many people know this, but it sells all of your data. So every time you use your claims, they package all that up and they sell it to PBMs, they sell it to manufacturers, they sell it to advertisers. And they also charge pharmacies every time they run that card, whether or not that the patient actually picks that prescription up. The pharmacy's getting charged. With this card, it is state-backed. It is administered by Oregon and Washington jointly. It's overseen by public servants. It does not charge pharmacies for every transaction. It is privacy first. It does not sell anybody's data. We would only receive, aggregate, this is how much we saved, but we wouldn't even get demographic data. They take privacy very seriously, and I think that is reflective of our values here in New Hampshire. So that is how it differs.
Do all discount cards work the same way?
Most of them work like how GoodRx does. Yeah. Mm-hmm. And you can go online. You can go online and you can compare the rates that you would get under GoodRx, and you can this card would be administered by ArrayRx. That's the entity's name, and so you can go in there. All pharmacies actually participate in ArrayRx's network already in New Hampshire. We just haven't launched that card. We just haven't done it yet. So it's another tool in the toolbox for consumers to help afford their prescription drugs, particularly if they're changing jobs or if they find themselves without employment or living on fixed income. This is just another way to help them.
Representative Tversky.
Thank you for taking my question. I believe tomorrow the full House is going to vote on House Bill 570, which is sponsored by the chairman, and there is a committee amendment. I'm wondering if you could speak to that and the impact of that amendment. Thank you.
Right.
And before you do, let me round out your question, please. I submitted two bills. I submitted HB 570 and HB 645. 645 was much more procedural. We're also voting on it. It was kind of a deeper into how we do business for the PDAB, and that came out of committee 17-0. So I think that was good policy that we put together with the help of the Honorable Gary Merchant and others. And then 570 was a kind of a simple bill to change some definitions, I think, and the committee decided that they would amend it to repeal the PDAB altogether. So
Right.
so tomorrow it's like we have to decide, are we repealing or are we fixing? And that's kind of what the bigger question is for
Yeah.
tomorrow. And now with that, please
Yeah. Yeah.
answer your question on what you think about those.
Yeah, I'll do the best I can. You're right. We had two bills that we were hoping to pass through the legislature. Thank you, Representative Edwards. And yeah, the amendment is unfortunate. It passed out on party lines. We would lose one of the only independent watchdog of prescription drug prices in New Hampshire. All of this work that we have put into standing the board up, to modeling savings, to building this up over time, tracking our spending, making recommendations, even if we may not have made a voluminous amount of recommendations, we are beginning to do so. And when I have highlighted those here today, all of the work that we are doing to help launch a prescription drug discount card, all of that stops. All of this work stops. We wouldn't have anybody that is making recommendations to state and local employee plans. I would also note that there are two municipal risk pools that are on the brink of insolvency. And this is a challenge that we are working to help, but that magnifies or shows just how big of an impact rising prescription drug costs are on this state. And the proposed solutions would increase costs, really would increase property taxes because of the risk of insolvency. And so if we can help these plans get a better spend or negotiate better rates, then we can help decrease that tax burden. But without it, nobody's there to step in and to perform that oversight function or bring the transparency to the market like we're able to.
Thank you very much.
You're welcome.
So I'll come over. Okay, going into today's hearing and in the last couple of months talking with the chair of the board, I tried to make it very clear that the investments that we've made into the board so far, I would consider in financial terms to be sunk costs. I'm not interested in going back and re-examining all of that because I know how we got there. But going forward, there's a couple of things. There's 645 has a fiscal note that adds about $100,000 a year, and the purpose of that $100,000 is so that the board can establish and operate a due process mechanism so that when the board sends questions to the private sector has an opportunity to respond. That's in 645, and that's the fiscal note. So my question on this now is because we don't have any money this year.
Right.
If we were to delay, the board were to delay querying the private sector, we could defer the 100,000 needed to set up a due process.
Sure.
So how do you respond to the idea that when we do see 645,
Right.
That an amendment might be appropriate to defer that we have to have it when the board starts to ask the questions.
Yes, absolutely. Great question. Glad you asked it. That was assuming we would have to add additional personnel. I hadn't talked with the insurance department. If we're able to establish the MOU and work with the insurance department or any other state agency on conducting a data call, then we wouldn't necessarily incur $100,000. We would leverage their existing infrastructure. But we don't have, I'm the only staff member, and aside from all of the work I'm doing, it was unfeasible to think that we could do that unfunded. But with working with the insurance department, I think we can do it without adding costs.
Okay, so
But I don't want to speak for
you,
DJ.
You think you could take that fiscal note down to zero, and
Yeah.
therefore you could start making
Yeah.
queries of the private sector
Yep.
while still creating a due process challenge.
Absolutely.
All right. If we get 645, we should talk about that.
Okay.
Okay.
Happy to.
So the other second thing is, so I was looking at this as an investment of like $550 million over the 2 years. And given that there was a thousands, excuse me. At least I didn't say
Like,
billions.
whoa, I'm going to be rich.
Yeah, 550,000,
Yeah.
sorry. So I wanted a clear business case.
Right.
So that we could demonstrate to the public, because we've got the House position on 570 is to repeal the board, right?
Well-
So what I think we need is a really clear business case to show how that $550,000 would return a rate of, there would be a return on that investment. Sort of a classic ROI analysis of, this is what we're spending, here is something that we think, and this will deliver, so we can deliver this at the end of this 2-year budget.
Right. I think it's important to remind the committee, we don't have enforcement authority.
Got it.
So we can't force anybody to take our recommendations. I provided savings estimates. We will continue to do that. Medicare is negotiating 15 more drugs this year. We'll do 15 next year. So that was 25 drugs this year that we'll estimate savings on. And this is stimulating a conversation about, are we overspending on prescription drugs? And if some,
So I just need an Excel sheet where you make a business case. And I know that you're not the one that makes the decision, but we need to be able to demonstrate how we think we're going to make this investment pay off. So are there questions over here, Representative Priest?
Thank you so much for recognizing me. Thank you for being here. Some of my questions have been answered before, but I'm on Medicare and I buy a prescription coverage through Aetna.
Yep.
Do they also sell my information to pharmacies and
Aetna,
as whatever that?
sure. Discount
Yes.
cards would do that. I know Aetna would not be selling your data
So
as
the
an
vetted
insurer.
first pharmacy discount card is not out yet.
No, and
You're
it's
still
not
vetting it.
insurance. It's not insurance.
Okay.
Yeah.
And the second thing is the number 550,000 has been floating around here, but your budget for 2026 and 2027 is 256,000
Per year.
per year. So you're talking about 550 for 2 years.
Yes.
Okay.
Right. And we have money for contracts for program services, 65,000, which is I'm not convinced that we're able to get a contract off the ground for that amount, but we are a lapsing fund, so we didn't spend 65,000. That goes back into the state coffer.
Okay.
So that's even, it could be less.
And the third question I have is, you have approximated about $6 million in savings. Do you have the number of granted staters that have participated so far in this program?
No.
No. And there's no way you can do that.
No, we were modeling the savings based on the Medicare negotiated prices compared
Right.
to what the estimated prices are that we're getting now, but no one is in that program. There are estimates on how many Medicare beneficiaries are benefiting, and we included that in the report.
You have?
Yes, we have included that in the report, the Medicare savings, yeah.
In this slideshow?
Not in the slide deck, no.
Could you just give me that
Yeah.
information? That would be very
Absolutely.
helpful. Thank you.
Yeah.
Other questions? Okay.
I-
Representative Novenko?
Yeah, thank you, Mr. Chairman. Thank you. We spoke in the hallway
Yes.
by way of full disclosure before the session. So I'm going to build on, I think, Representative Seaworth's question and as well as Representative Priest. So what we've got here is basically the 6 million is a theoretical number of potential savings. And so the question, and I think it also relates to what Chairman Edwards was saying, I don't see, what's the mechanism for you being able to identify how much of the potential savings, however you're defining that we're actually realizing. And I would imagine that there's a significant I don't know what the number is of uninsured or
Sure.
underinsured people, and it's not clear that how you reach
Yeah.
those people. I know you reach out to, for example, the state employees unions and I guess, and provide them with some information on affordability or
Yep.
where the cost structure is detrimental. So, and then as a second question, in your presentation package here, you show I guess a calculated number of $241 per script. And I'm guessing, and maybe you can tell me where that number comes from, because I'm
Yep.
guessing that it's on the really high priced
Yeah. Yeah.
prescription drugs, but not really a representative average of a full spectrum of drugs that people use.
Sure. Sure.
Thank you.
So for the first question, we are providing directional information that can point you directionally to informed policies. Now, you all are the policymaking entity. We are empowering you all with the data. We are empowering plan sponsors to go back to their PBMs and say, well, the PDAB modeled these savings and we're not getting the best discount, or why are we not getting that price? They can go to their plan sponsor and ask that. We are empowering them to do so. And then we want to work with all of you to figure out what is the right mechanism. We currently in statute don't have that mechanism, but we would love to explore that, and we are working over time to get there. Your question about the uninsured. So our recommendations by statute are for state and local employee plans, not uninsured. That kind of limits our reach, and that's a policy decision. But I think we would also welcome the opportunity to help folks that are uninsured as well. But that was the uninsured question. $241 per script. Yes, that the card saves on average about 80% for generics, 20% for brands. When I was talking to Connecticut about their experience, they're seeing a lot of folks use it for maintenance medications, for chronic conditions. Often Medicaid doesn't cover OTC or over-the-counter drugs. So there are Medicaid recipients that have to go and use that card to afford their prescription drugs. So they are also hearing a lot from folks with high deductible health plans that they are using that card a lot for some of their drugs, that when they have seen that it's gone off their formulary. So I don't have specific names of the drugs, but those are hopefully can give you a sense of who is using it and for what reasons, what kind of drugs.
A quick follow-up.
Okay, so
I am.
the protocol is, once you have the floor, as long as you're asking relevant questions, just have a conversation. So keep going.
I hope it's a relevant question, but
well,
you may
you'll
not be
know.
able to tell. So the savings and everything. Recently there was a cut in what they're able to charge for something like insulin,
Yeah.
which is an ongoing cost. So is that reflected in or still something that you're looking at?
So, the insulin issue, that, if everybody remembers, 3 manufacturers controlled insulin, and over the period of about a decade, the price increased 600%. Individuals were rationing insulin, which is a life-saving medication, due to a lot of public pressure. A lot of states started to cap copays on insulin themselves, and so we have done that in New Hampshire. New Hampshire has capped out-of-pocket costs, and the manufacturers, again, due to a lot of scrutiny at the federal and state level, they did voluntarily lower their prices, but that's not necessarily reflected in this report.
Okay, I want to the point that was made here on 645 expands the scope of what the PDAB can look at, because we didn't have the statutory authority to get the Department of Corrections money. And I think that was one of the things that Representative Merchant and I and Senator Rosenwald wanted to make more clear.
Right.
So with 645, we included corrections. And to the extent that there are other categories we can always
Yeah.
expand the scope if it's appropriate.
Absolutely, and that's a great point. And with with the ArrayRx discount card, they also have a voucher program that is available to correction facilities. So that would give folks that are re-entering the community a voucher to help afford their prescription drugs and ensure a continuity of care. And that's something that we can look into and would be maybe a future recommendation that we would make.
All right, so Representative Seaworth and then Representative Stringham, did you still have a question?
I think I'll wait for now.
Okay.
Thank you, Mr. Chairman. I'd like to jump back to the $65,000 contract. It sounds to me like you've established a need. You haven't found a way to fulfill it, and then apparently you're somehow doing without right now. So I'd like to understand what's going on. And
Yeah. We have, the line item for contract for program services. Since we only have one staff member, additional consulting manpower to expand the bench of folks that are able to help operationalize the spending target and reviewing this data, helping to make the recommendations. We are looking to procure expert services. Some of the feedback I've gotten from folks that would bid for this is that it's far too low. So we may not be able to actually get it out the door, but we are working with the contracts department. And I would also note that we have the extra requirement of having every contract approved by the fiscal committee in addition to GNC. So unlike every other board in the state, we have that additional requirement. So that slows our ability down to actually get it out the door or get the assurances for folks to bid that, it's worth their time. Yeah.
Representative Stringham, is this later? Do you want to ask your question now? Representative Daniels?
Thank you. In addition to discount cards, are you
Yeah.
also looking at other discount programs like Cost Plus Drugs?
That's a great question. Cost Plus Drugs, established by Mark Cuban, that's largely a generic relabeling company. That we could explore, how plan sponsors could work more closely with Mark Cuban's Cost Plus Drugs company. That's a different type of reimbursement framework, but I think it shows that there is a problem with how drugs are priced because he does show very transparently what is the cost of goods and how much is the drug or how much is it going down over time, whereas other manufacturers don't do that. And I think it's a great effort in transparency. It doesn't solve the issues that are facing the plans, but it could be one way we could help bring about savings. I think that's a great idea.
All right. Okay, so we said we would come back to page 7.
Oh, sure. Yep.
Go ahead.
I thought you had a question. I'm sorry.
No. You have
this is just
lot of
other. Yeah, these
information
are.
here.
Yes, sorry. These are explaining in kind of more detail some of the line items in our budget. So there are general administrative functions. For example, one state-issued cell phone that helps ensure compliance. And safeguards, my email, any sort of documentation. This helps to, underneath this umbrella, we are able to tap into regulatory and policy resources, and it also helps to support the software tools for data analysis and reporting. And I may have failed to mention this, we are an independent entity that is administratively attached to DHHS. So we share and we reimburse them for the costs that we incur. So some of this funding does help cover those costs, and so we don't have staff that we pay. Then we have travel and professional development that allows for attendance at one state policy conference, notably the National Academy for State Health Policy. Most recently, I was nominated to the Academy, actually, and I'm on the coverage cost.
Congratulations.
Thank you, and I'm on the coverage cost and value steering committee.
You're probably on some cover of a magazine, too.
Maybe one day, only if you fund me. And it allows for meeting with stakeholders, engagement in national policy discussions. Last year, I attended a legal conference in Washington, D.C. by NASHB to help stay up to date on current legal.
Is 5,500 too much? I've gone to lots of conferences, and I never spend anywhere near that. I'm a $2,500 trip guy.
Yeah, part of this is, Yeah, I think the for that conference it's something like $750, and then there's airfare and hotel, but it's also in-state travel, out-of-state travel. I meet with stakeholders. I travel across the state to meet with folks, so that helps reimburse that. And then we touched on programmatic support, and we're currently at $65,000 a year for contracts.
Okay, so this programmatic support, this is if you issue to the Department of Insurance a request to do some sort of new data query or to do some data
I guess we could
analysis.
use it for that. Is
Is that what this is for? I mean,
Well, it wasn't intended for that. It was intended for, consulting expertise. Many departments, boards, they have contractors that assist with data analysis. Now, if we needed to do that, then, we could maybe repurpose it for that function.
Yeah. Okay. So my thought has been that so far we've been living off of the largesse and generosity of the other state departments that they've incurred costs to support the establishment, of which no money has been transferred to compensate them for it. And so
We have an MOU that does cover the
but have we
costs
sent
incurred.
money?
That would be a question for Nathan,
Yeah,
how
I
that
don't-
gets
I don't
done.
think-
I don't know how that gets done.
I don't think we have, but
Well,
okay. So, all right. So that seems fairly reasonable.
Okay.
Are there
Thank
any
you.
other questions? Mr. Merchant, do you have anything to say to us? I mean, you've got the most skin in this game. You've been doing this for over 4 years. Is there anything you want to add? And the reason I'm belaboring this, to some people think I'm belaboring it, is because we have a legitimate effort to repeal the board, while at the same time we have a legitimate interest in
Right.
this being a successful board.
Right.
So this is just a much bigger decision, I think, than $500,000 over 2 years. It's a bigger decision. But go ahead, the Honorable Gary Merchant.
Thank you, Mr. Chair. For the record, my name is Gary Merchant. I'm the chair of the Prescription Drug Affordability Board. I am pleased that we have Executive Director Kurt Williamson here today to answer all of your questions. I would say we're at the cusp of, fundamentally, do we try to continue supporting the board with the work that's been done and continue to work on prescription drug pricing affordability for the residents of our state of New Hampshire? It's one of the number one issues in healthcare cost. We're on the cusp of making some really good recommendations to different entities. We put a lot, as a state, we've put a lot of effort and resources in getting the board up to where it is today. Until Mr. Williamson came on board in January of 2024, we couldn't really stand up the board. So I think to your point, Mr. Chairman, it's at the point of let's continue down the road. Give the board the opportunity to bring the recommendations forward. See where they go. $6 million potential savings is a lot of money. A discount card could save our citizens over $1 million a year. A voucher program. These are only the beginning of what we're finding. So as you go down the road and begin to analyze the data, we're finding more and more things. And the more we find, the more we can bring forward recommendations. So my thought is, let's not fix it, but continue down that road for the benefit of our citizens, also for, most importantly, our taxpayers.
Okay. So when I ask for a business case analysis on the specific recommendations, there's something to it. And we're asking you to be a jack of all trades, right? You came to the board with a particular background and education. You get asked to do a little bit of everything well. So if you don't have any experience with business case analysis, I'd be happy to change hats and help you as a board member to get the right format together. But I do think if this rolls into the Senate, that you want to have much more clarity about what the recommendation is, and how we're going to make money doing it. So, yes.
If I could, Mr. Chair, the return on investment, there's twofold. One is the fiscal side of it, the other is societal. And trying to look at it and saying, what are we doing to help our citizens in New Hampshire to make drugs more affordable? I totally agree that we have to have a business case on the fiscal side, and that's critically important, but also not lose sight of the fact that we're trying to help out many folks in the state of New Hampshire to make prescription drugs more affordable. The discount card, for instance, may not save the state itself directly money, but over $1 million a year in savings to the citizens of New Hampshire is a significant amount of money. When you start looking at Department of Corrections, so there's things we can do, but I want to be clear with you folks and everyone else. Yes, we have to focus on the fiscal from an ROI point of view, but not lose sight of the fact there's also societal impact.
See, I see that. I hear you. I see that as a distinction without a difference, though. I think we can still do a business case even if the state is not directly benefiting from it, because this is all state money. So if we're making things better for the taxpayer through some other mechanism, I think all I'm talking about is visibility and transparency, so that when people want to know exactly what the benefit of this program is, you can lay out some hardcore numbers. That's what I'm hoping you get to.
And I think we're on the same page, Mr. Chairman. And I want to say also recognize, it wasn't so much in the report, but with your guidance and your oversight, that the issue of the data and having the ability for the board to get available data.
Yeah.
And at that point in time, is the board should not really be in a place to collect the data, but being able to work with other state agencies that do collect the data so we don't have to reinvent the wheel or build the infrastructure, is be able to have what they call a data call, to go to them and saying, this is the data we need. You have something in place so we don't have to, again, be redundant.
Right.
So thank you for that.
Sure. I know it's been unpleasant because we've wanted to get to the same point, but we've been bumping into each other for 4 years. So Representative Stringham.
Well, first of all, I want to say thank you for all the hard work and progress that's been made. I was considerably frustrated 2 years ago because going through line by line in details of the budget, we realized that prescription drugs is a huge percentage of the Medicaid budget, and we spent maybe all of 15 minutes on that out of the weeks and weeks that we combed through the budget. Virtually no ability to impact what is prescribed or how much we pay for it. And so, I look at, these last 3 pages that are in there, that we have a relatively small number of drugs costing $60,000 plus per patient a year. Mostly in here, we're looking at the Medicaid budget. But one of the frustrations, if that budget continues to grow and consume a bigger piece of the Medicaid pie, sooner or later, the pie is going to overflow the pan. Thank you.
Exactly right. And one of the bills, unfortunately, the bill that was amended to repeal the board would have expanded our authority to also assist Medicaid. And that was, we thought we were supposed to look at Medicaid, but there's been differing opinions on what the statute actually said, and this would have fixed that. So we could have helped address a lot of that, what is a growing line item in Medicaid. And a recent report by MACPAC, which is the Congressional Advisory Council that advises Congress on Medicaid, they documented that the cost of brand name drugs in Medicaid doubled from 2018 to 2022. These prices are growing. And as more gene therapies are coming to market at over $1 million each, a lot of these target Medicaid populations. So I think that is another area of growing concern, and will add to budget uncertainty over time if not addressed. But we are here to help address them. We are here to be a resource for you and for other legislators and the public and public payers. So.
There's not a lot in 570. I mean, the amendment obviously is a big deal, but if 645 continues to progress, the legislative process will have an opportunity to amend 645 so that we don't lose the good stuff that's in 570. So it's not done. We're in the middle of we're still at the relatively beginning phase of a process. So, all right, if I don't see any other questions, and I think, have you wrapped up? Because I need to ask the audience if there's anyone in the audience if they want to speak. You guys, thank you. This went longer than I anticipated. But,
Thank you, Mr. Chair,
all right.
and the committee.
Okay. Is there anyone in the audience that wants to speak? Anyone? Okay. So where are we? At 2:00, we're full finance committee down in Reps Hall. That's expected to go many, many hours. I wasn't able to verify whether or not food is going to be provided if we go past 6. I think that's a house rule that the speaker or somebody can procure food if we go past 6. And then Thursday, what are we doing Thursday, Madam Vice Chair? That's the House session. So our next time that we're going to get together is Monday. Has that been put in forward to go into the House calendar?
Yes, it has. So you'll meet Monday at 10 a.m. For bills, and that fourth bill still needs to be added, the bill relative to the county payments. So I've
Yeah,
asked Janet to
if
do
they
that.
really want to keep that, then I just want input to it, and I'll work that out. But if it gets into being, no,
Okay.
I want it, I don't want to fight over it. We've dealt with that issue more.
Okay.
Yeah. Madam Vice Chair, yes.
Thank you, Mr. Chair. So during that last presentation, we were distributed statutory language. I'm not sure that was discussed or if it should be discussed, but just thought I would bring that up now since we were all given a handout.
I think the value of the statutory language was the strike through, right? The position shall be effective.
Can I address that?
Yes-
Okay.
yes, sir.
Yeah, so that was included in HB 570, but this is a technical amendment for some reason, my position expires within 2 years of my hiring date. So this would just eliminate that 2-year term limit, essentially.
Okay, so I think the people I've heard on this that understand this better than me is that we should have. This is a little personal, but just speaking at the policy level,
Sure.
I think it's true that all positions in the state basically continue, and your position is recorded as permanent, is it not? Or is it temporary?
No. It's just like with any other position, if the board's not funded, I'm not funded. So
Right.
I'm not like permanently in
But-
statute.
But if it's continued to be funded, there's no axe getting ready to cut you.
There is.
There is?
If that's not fixed, then I that is the axe. Yeah.
Okay, so, all right.
Yeah.
If we get one of those bills in here, we'll keep this in mind.
Okay. I appreciate it. Thank you.
All right.
Mr. Chairman, may I ask a question?
Yes, ma'am.
Mr. Ripple, would it be appropriate that this amendment be part of House Bill 2 in order to ensure that the position continues if it stays in the budget?
It would be, yep.
Thank you.
That's an option. Yep. Representative Priest.
Thank you, Mr. Chairman. Just as a comment, thank you for everything you've done. I didn't realize you've only been here for a year now, and it's a large task, and you're doing it very well. You and the
That
board.
goes a long way. I appreciate that.
Would like to commend you and Representative Merchant and the rest of the members on the board for what you've done so far.
Well, I really appreciate it. And I really appreciate the support of the legislature. So thank you all.
Okay, thank you.
Okay, well, I think that's it. So we'll go ahead and adjourn today's work session. See you at 2.